Thank you. Thank you for having me here today. Following these other talks, I started writing all these notes because there are just so many interesting things that come up, and everything is so intertwined. It's hard to talk about the workforce without talking about financing or education or other issues. And so just kind of two broad contextual things I wanted to talk about before I get started that made me think during the previous talks is, especially from a policy point of view, it's very different when you think about something at the individual level or a population level. And in policy, we have to think at the population level. We have to be concerned with everybody. So while there are policies you need to think about and wrestle with, it could be very different of what you would do for your child or your mother versus what is best to try to serve everybody. And that was very similar, I thought, to Faye's remarks about, pooling risk. And, it's very different when you think about one individual person and their risks versus thinking about the population as a whole. That's kind of how I found that similar. And then we also had some interesting information about utilization versus access. Do people need to know that they have to go to a dentist or someone else? So education, literacy, that is hugely important. I can tell you anecdotally, I'm a podiatrist, and I can tell you more about that. But until I worked in oral health studies, I didn't know cavities were infectious. Didn't know that, never heard it. I'm the daughter of a dental hygienist. I think I'm a pretty well-educated person. That's a pretty basic thing probably to all of you. Everyone on my team, none of us knew that. I heard stories of dentists that work in Appalachia, and there a commonly accepted graduation gift for high school is a full set of dentures. And that is their expectation. They don't know to know differently than that. So the ability to know that you need something is very important. But I also think, and this is what leads us into workforce, there really is an access problem in this country. It's not just people needing to know that oral health is important. And so I actually if you saw me fooling around up here for a little bit before, I wanted to sneak in some pictures. Have any of you participated in or heard of Missions of Mercy or these dental clinics that come together and you serve hundreds, maybe thousands of people, and it's a one-day clinic, and all these people come in and they come for their care. Have you heard of this? You've seen it maybe? Okay. So I grabbed a few pictures of what these look like. People will line up for 9, 10, 11 hours, camp overnight to get care. They stand in the rain to get care. It's wonderful to do these things, and I'm not saying they're not necessary, but this is not solving a problem. This is not a model of care. This is not how people should be getting care on a permanent basis. And these are not people, I think there are huge literacy issues among this population, but I would argue that these people know they need some help and they want to get it, and this is the only way they can. So anyway, so back to my presentation here. So what I'm going to do for you today is give you a very quick introduction about what the Institute of Medicine is. That is IOM. When you're in Washington, everything is acronyms, as you heard earlier, so I'll try to avoid that. Quickly tell you why I am a podiatrist, and I'm here to talk to you about oral health workforce. So I've worked on many issues related to the overall health workforce. So we tended to use the terms the dental workforce and the non-dental workforce. It's not a great term. It's kind of like when people hate when we say physicians and non-physicians, as if everyone else is dumped in one large bucket together, but that's the best way to think of it. And then really what I was asked to come to talk to you about today is not to really talk about, who should be doing what. There are huge political tensions and debates about that. But I really want to show you is that there's a lot of things going on, new types of providers, using people that we have already in different ways. And just to show you sort of the breadth of what's going on out there and, as you heard in the opening, people that you're going to need to work with and figure out how you're all going to work together as a team. So very quickly, the Institute of Medicine. We are not the NIH. Let me start there. That's what most people think. We are an independent, nonprofit, nonpartisan, I should also add in there, organization. We work outside of government, and our role is to provide advice. We were established originally in 1863, so if you do the math, this is our 150th anniversary this year. We were chartered by Abraham Lincoln, and the purpose was to provide scientific advice to Congress on matters of science. And so what we do, I should say, this is just a very quick overview. A lot of terms, hopefully you've heard of us in some way before, but we started as the National Academy of Sciences. Over the years, different arms have grown. I work directly under the Institute of Medicine, which started in 1970, and as the name indicates, we work on healthcare medical issues. The other parts work on everything from aerospace to geology to every other type of science you can imagine. Collectively, we're known as the National Academies. And so what do we do? Our main role is either Congress or an independent agency or even the private sector will come to us with a set of policy questions that they want answered. Our job is to look at evidence, to look at peer-reviewed journals, to take testimony, to ask professional judgment, and then put all of that evidence together and come up with a set of evidence-based recommendations. And I keep emphasizing evidence because that's really what our task is to focus on. That is what we are largely known for. We also, we call those consensus activities. And so the idea is we work with experts from around the country to look at this evidence and come up to consensus on a set of recommendations. We also have a series of what we call convening activities. Since we are seen as a neutral organization, we bring together people with biases and conflicts of interest to talk to each other about a variety of topics and hold workshops, hold what we call forums and roundtables. I can talk to you more about that on the side if you'd like. And lastly, we are an honorific organization. You will hear of people who will say they are a member of the Institute of Medicine. That is separate from these activities. Even as staff, we are largely separated from that, but it is definitely a distinct honor for people to be inducted as a member of the academies. This is very blurry because this is the days before PowerPoint, certainly, and I think probably largely computers. But this was one of the first reports I could see out of the Institute of Medicine that directly related to oral health. So this is public policy options for better dental health. This was actually charging the group to consider whether oral health should be included under healthcare reform at that time. If I'm recollecting, the healthcare reform moves actually died while this study was in progress, so it sort of became a moot point. But they did ultimately conclude that oral health should be included in any plan that was being designed. And interestingly, related to workforce, even at that time, which is 33 years ago, there was a lot of debate and discussion as to how dentists and dental hygienists should be used. And in this report, they did talk about using them to provide preventive care in school settings. And these issues are still being debated and discussed today. Move forward to 1995. A lot of the folks in the room may be familiar with this. Was a study that was done to talk about dental education in the United States. And again, there was, even though it was focusing on education, there still was a workforce in the mix there, and talked about the, quote, more productive use of allied dental personnel. So I put this in here for a lot of reasons to show you that these are not new issues. They're issues that are going to continue about how to best use the workforce to deliver the care that's needed. So the reason why I'm a podiatrist is here talking to you is that I've been at the Institute of Medicine for 9 years, and I've largely worked on all parts of the healthcare workforce, workforce for geriatric patients, allied health, telehealth, and in 2009 I started the first of the recent work on oral health, which is the one to the left and was available to you today. It was a workshop we held, a 2.5-day workshop on the U.S. oral health workforce in the coming decade. As a result of that work, we then the Health Resources and Services Administration, HRSA, came to us. It was interesting through two different parts, but at the same time, asking us to do two different studies related to oral health. The first one was called Advancing Oral Health in America. For those of you that know, the Surgeon General's report that came out in 2000 was called Oral Health in America, and this was sort of we titled it in some ways as an homage to that, to say these same problems still exist. And that had to do more with how the Department of Health and Human Services, what they should be focusing on in oral health. The second study that we did, and these two were both released in 2011, had specifically to do with what we're mostly talking about today, which is how to improve access to oral health care for vulnerable and underserved populations. So I use the term oral health workforce. It was talked about earlier, health versus health care. Words are very important. And I also didn't use the word dental here because we really were thinking more holistically about the workforce and who is helping to provide oral health care and services. So we have dentists, hygienists, assistants. These are the main people providing care. There's certainly other people in the mix there. Physicians, we've heard a little bit today, and I'll talk some more about, are becoming more and more involved in oral health. There's a study by Gies in 1926 that advised physicians that the phrase we use is that the mouth is part of the body, and they should really be paying attention to it. My nurse colleagues would never forgive me if I didn't mention we quibble a lot in workforce discussions about who should be doing what, and 164,000 dentists and this many, and there's 3 million nurses out there. And that's a lot of people. I'm not saying all of them are the right people to be engaged in oral health, but there's a lot of them, and they do touch children. They touch their health care every day. Pharmacists are becoming increasingly involved. People go up to the counter in their local pharmacy and say, "My tooth aches. What product in this pharmacy should I use?" Nurse practitioners, physician assistants, and then public health workers. These are the people who are in the community that people know and trust. They're neighbors, and are increasingly being used especially for education about what they should know and what they should be doing. So first, starting with the dental workforce, and this is also one of my disclosures. That's my mom on the left. She was a dental hygienist for over 40 years. And so, in general, in the dental workforce, we're referring, I said, dentists, hygienists, assistants. And among these members of the workforce, again, we're both considering expanded roles for the people that we have, and then developing whole new types of providers, ones that haven't existed before. For the non-dental workforce, again, nurses, pharmacists, physician assistants, physicians, community health workers. Evidence shows that many of these individuals are well-suited and willing to integrate oral health care into their primary care, but we overwhelmingly see they're not being trained in how to do this. And they have a significant role to play, especially in oral health promotion, disease prevention. So this is, so at this point, really, just what I want to do is quickly run through lots of different models that are being tried, have been tried, or at various stages. Again, I'm not looking to say that one is better than the other or one is the solution. None of these is going to be the solution. And in fact, the workforce isn't the solution. But we have to consider that workforce is part of the solution, and some of these models may be part of the solution. Not every type of provider is going to work in every community. The 500-person community in rural Oklahoma is going to need a different model of care than here in New York City. It's just different needs. So independent dental hygienists, this is not a new concept. In the 1970s and through the 1990s, there were multiple studies showing how to train hygienists to do specific types of restorative care. This is an independent dental hygienist is where a dental hygienist can provide assessment and some services without the authorization or presence of a dentist, and they can maintain their own patient-provider relationship. In many ways, it has been compared to the evolution of the nurse practitioner, and battles exist in the nurse practitioner field as well. I'm not going to say that has solved the problem either, about the levels of supervision that are needed, the types of relationships that are needed. But as there's also a concept of the reason we need to discuss all these different models and comment and work together on them is they're happening. Whether you agree with them or don't agree with them, they are happening, and so we need to talk about them and decide what's working and what isn't. As of 2010, 32 states permit some form of direct access to a dental hygienist, and 15 states had direct reimbursement through state Medicaid programs. There are mixed results in whether or not this model improves access. It has been shown to work in some places, and there's been other places where it hasn't helped solve the problem. And the reason being, some of the issues that face an independent dental practitioner, any type of dental practitioner, are the same. Is there a population that's going to support a practice? You know, the payment rates are the same. If payment rates are too low, it doesn't matter who you are. So there's the same issues going on. This is an interesting model, registered dentist, dental hygienist, and alternative practice. Very similar to what I just talked about, but it's a very specific model in California. It was developed in the 70s and 80s. The legislative requirements didn't evolve until 1997, and the first person licensed didn't happen until 2003. So again, these are not things that are just sort of like popping up and happening. They've been going on and boiling up for a while. This is a licensed dental hygienist who then receives additional training, and then they have to get licensed. And there are very specific requirements. I'm not going to get into all of that. There's currently 287 of them. So again, this is not something that's overtaking all the practices out there. The evidence does show that they are working primarily in underserved settings, and that's part of their requirement. They do require that there's a dentist on file for referral, consultation, and emergency. And in order to get continued care after 18 months, they call them RDHAPs, but they have to get a prescription from the physician or dentist to allow them to continue to get care. I actually repeated myself. The evidence, what we have seen with these practitioners is that they are primarily providing care to vulnerable and underserved patients in a variety of settings. When they looked at the patients that were being served, the majority of them in the interview said that if it were not for this practitioner, they would have no other source of care. And just as an example, more than half of their patients have a physical disability. So they are, it seems that they are perhaps a way to serve some of those populations that just really are not able to access a more traditional setting of care. Also, overwhelmingly, I know that this is focused on pediatric, but they overwhelmingly serve people who live in nursing homes and have other, they're just in other settings that just can't get to our traditional offices. So this is probably the most politically charged model of care that exists. You may have heard of it, you may have not heard of it, but the dental health aide therapist. In other countries, Australia and New Zealand, they have used a model similar to, it's again trying to think of it as like an advanced dental hygienist, someone that has received training. This is a 2-year program. Australia and New Zealand has used this since the early 1900s. And I'm also going to say there still is oral health disease in New Zealand and Australia, so obviously it's not solving the problem. This is just, we have to think of this as another tool in the toolkit to try to serve people. There's a lot of politics behind it, but a small number of people were trained in Alaska. I think you could imagine Alaska has a pretty severe shortage of people available to care, especially to fly into bush countries and treat people there. One of the interesting anecdotes I had heard in doing the studies was talk about oral health literacy. People in Alaska will put Coca-Cola in their baby bottles, and when asked why, they said it's the only thing that doesn't freeze. So it's kind of horrible, but that's again, it's a cultural literacy issue that really needs some addressing. There have been very limited studies to date because we don't have huge numbers. You know, people like me that like to work in evidence. An N of 10 people isn't going to give you a great evidence base, but it's all we have in this country. And all the studies to date that have been done, and actually the ones that have been done, I think we're only on 5 of them. So while it's not proof that this is, the solution or improving access, in that limited number, it did show the people that provided the care, the quality of the procedure that was done was equivalent to that of the dentists in the area, and patients were satisfied. That's all we have to start on. We don't have huge amounts of evidence. Let's not forget our dental assistants. Expanded function dental assistants have been around for decades. And all of these, again, are examples of using people we have, and I'm not talking about allowing people to do things they're not trained or qualified to do. What we're saying is we need to think about what are discrete tasks that we can take out and give to other people to do. All of you work with people and have delegated tasks to them. An example I always love to give is that 100 years ago, a nurse would never take a blood pressure. That was a doctor's job. Now, we would find it kind of odd for our doctor to take our blood pressure. That's not a high-skill job, but it's something that needs to know how to be done, and we've learned how to delegate that task. This is before, automated blood pressure cuffs. So, expanded function dental assistants. Studies dating back to the 60s showed that they could be trained to do certain specific tasks with equivalent quality. The military and our Indian Health Service currently use them very extensively. There's a variety of titles, a variety of duties. It depends on what state you can go to, who can do what. Here at the bottom are some of the tasks, just as examples that many states will allow expanded function dental assistants to perform. Community dental health coordinator. This is an example of in a sense, a completely new type of practitioner for the dental workforce. This was developed out of the ADA. I have to admit, my work in oral health stopped as soon as these reports came out, so I can't tell you what the status is of some of these models. At the time we were doing the study, they were being piloted, and we had written in our report that they were supposed to be evaluated close to now, so maybe that's happening. I'd mentioned our community health worker, and that's what this is. It's a type of community health worker. Someone has training and internship. They provide limited preventive palliative care under the remote supervision of a dentist, but they're really focusing on health promotion and behavior change, risk assessment, patient education, screenings as needed, and this is really great for helping to find all those people that don't know they need to access care. That's an example of where they'd be most helpful. Lots of other models are being tried. These are all examples of advanced dental hygiene practitioners. Some of these I think don't really exist anymore because there were several different models all trying to do the same thing. And I can't go without mentioning what Dr. Edelstein came to talk at our workshop about, which was a theoretical model, which is really to think about a pediatric oral health educator, just like we have diabetes educators that are out there and talking to parents and children. But this would be someone that really targets parents with young children who have an active disease process, early childhood caries, and focus on chronic disease management and behavior change, really thinking of this under the chronic care model, as this is a chronic disease, and getting them to understand and manage, and would be better, obviously, to prevent. But again, think of that diabetes educator that's if any of you have had experience with, but really their whole job is to get people to understand their disease and how to manage it. So moving on to our non-dental colleagues. There are really a lot of places that non-dental professionals have a role to play in oral health. They can incorporate oral health into a basic routine exam. I heard sort of mentioned similar to this earlier. I used to say I think of physicians as they sort of push the tongue and everything else out of the way to get to look at the back of your throat when they look at your tonsils. But they really should be at least looking and seeing obvious pathology. Basic risk assessment, oral exam, anticipatory guidance, basic preventive services. These are where we really see as a role for these individuals. There are reimbursement barriers. It's getting better, but a lot of places there would be pediatricians who would say, I'm willing to do these things, but I can't get paid for them. Goes to our discussion about financing. And when you're paying for a specific service by a specific person, this is what happens. Other barriers, oral health literacy. So oral health literacy of patients is not the only problem. You also heard earlier that your medical and nursing colleagues also have oral health literacy issues. I have a medical doctor that I work with who talks to me about going to get his teeth polished. A lot of, they don't, and I'm going to talk a little bit about the level of education and training of the non-dental workforce. And time. Or skepticism, is this worth it? Should I be doing it? And which ties to literacy, confidence in their skills. They haven't been trained. So, now you're going to tell them to do something they don't feel comfortable with. And the time. Time is always a thing. I've got a 15-minute, well child visit. Now you want me to put in a whole other set of tasks to do. So pediatricians, this is just some facts and figures from two studies, one a little bit older. But from a 2000 survey of pediatricians, more than 90% thought they had an important role to play in the recognition of oral diseases and counseling on the prevention of caries, and 3/4 indicated they had an interest in fluoride varnish application, but half reported they had no oral health training in medical school or residency. That's a lot. 2009 survey of pediatricians, more than 90% thought they should examine the teeth of children 0 to 3. More than half reported doing so. We'll see, but 41% of them cited lack of training as a barrier. So this is an example, I think, of doctors and nurses and others. They want their patients to be healthy and they're interested in it, but they just don't know what to do or how to do it a lot of times. Pediatrics residents, this is 2/3 of graduating residents in a survey thought they should be performing oral health assessments. Only 1/3 reported receiving any oral health training in residency. Of those that did, 2/3 had less than 3 hours, and only 14% had clinical observation time with a dentist. Nurse practitioners, similar. More than half feel unprepared to do a thorough oral health exam. 78% felt unprepared to recognize oral symptoms of systemic disease. And 60% felt unprepared to discern obvious oral pathology. Physician assistants, a lot of the same. Only a little more than half felt competent performing an exam. Only 63%, a little more than half, thought they could discern obvious pathology. And about 1/3 thought that they could recognize oral symptoms of systemic disease. So this kind of goes back to that, yes, the mouth is attached to the body kind of conversation. Here are our medical and nursing and other colleagues who can't even, tie the symptoms that they're looking at. As I mentioned, pharmacists, they're increasingly becoming involved in care. Patients are coming in to a pharmacist and saying, I have a cold sore, what should I use? I have pain, what should I use? They also have a role potentially in the management and treatment of disease, like I said, selection of products. Think about how they're doing now vaccinations in pharmacy clinics. Again, I'm not making a judgment call. I'm just saying these things are happening, and we need to think about how to best use all the members of our workforce. And there's been no formal assessment that at least we had at the time of what their education level is like about oral health. And so even, I'm talking to you about workforce, but it's hard to, as I've sort of said, education and workforce are sort of inextricably tied. So I wanted to give you some examples of some improvements that are going on in the non-dental education world. So at the University of Washington Medical School, they've actually developed a set of oral health goals and competencies that all of their medical students are being trained in. In terms of residency, the ACGME, now I know you're going to ask me what that is. It's the Graduate Medical Education Group, requires all residents, all pediatrics residents, to implement age-appropriate screening, including oral health. Family medicine residency, they added a requirement for oral health that was added in 2006, although there's some interesting data we had in our report that shows that while it's a requirement, I think it was only 2/3 of residency directors were aware of the requirement. So again, it's a lot of education that's needed on many levels. In terms of graduate medical education, the family medicine residency folks, or I should say family medicine physicians, have developed what's called Smiles for Life. This is online oral health curriculum that's available they've developed it now for all different types of primary care providers. So for physicians, for nurses, and others. Some examples of things that are happening on the non-dental side. So here was a pilot in North Carolina called Into the Mouths of Babes. The target was children birth to age 3. And the goal was to improve practitioners, meaning pediatricians' knowledge of oral health, so that they could provide some counseling and fluoride varnish application, and to increase screenings and dental referrals. Something that always makes people nervous is, now that these people are doing my job, what am I doing? We're not looking for people to take over other people's jobs. And in fact, we often see it as the more disease that's out there that's identified and brought into the right channels, the hope is that it would refer to the correct people to take care of the problems. The results of this particular study showed a 10-fold increase in the number of preventive procedures that were being performed through physicians' offices. I shouldn't say through physicians' offices, but just overall preventive procedures. Another program, Washington State Access to Baby and Child Dentistry Program, ABCD. Again, it was the use of primary care physicians where they were trained in screening and fluoride varnish application. Also to let them know how to do an appropriate referral, and it increased reimbursement because, as has been talked about, Medicaid reimbursement, I don't know if you know, but is not exactly great. The dentists, provided advice on training to work with young children, case management for families. There's often a tendency to put a lot of blame on patients, certain populations that, they don't show up for their appointments. They don't do this. And this is part of the education process. They need help with, and so case managers have been doing a lot more to help families in understanding the importance of showing up and doing these things. And again, for the dentists, they provided increased payment rates. So the results, again, were mixed. Overall, more Medicaid children received care. There was a decrease in the untreated dental decay among all children, but there was this blip where there was increased decay among low-income 3 to 5-year-olds. And this is a little bit in the weeds, but again, I want to make the point that no single model is ever going to be perfect and is going to ever solve every problem. Really interesting, right here in your own milieu. At New York University, the College of Nursing is located within the College of Dentistry. They really, sorry for the typo, really the focus is interdisciplinary education. So the pediatric nurse practitioners and the dental students work together in clinic. The nurses learn about caries risk assessment and how to apply fluoride varnish. And the dental students learn a lot more about how to work with their nurse practitioner colleagues. And it really is focusing on team-based skills. And then, something I was going to sort of get to at the end of all this, but is I'm talking to you about all these different parts of the workforce. And we train everybody, and we train nurses, and we train doctors, and we say, and you all should be working together. Okay, now go out there in the real world and work together. And a lot of schools are now really beginning to understand the value of training and skills of working in a team. It's how shocking and revolutionary. But so this is an example of how that's working in one place. So in our report, I pulled out a few of our major findings and conclusions related to workforce. And so again, the non-dental workforce is largely willing, but have inadequate education and training in basic oral health. Training of primary care can lead to increased recognition of disease, increased access to preventive care, and decreased disease. Regulation of the dental professionals is characterized by polarization over scope of practice issues. early experiences with new dental professionals do not raise concern for quality. And this is what I was saying about based on the limited evidence we had. I always try to make it clear when I talk about these reports to say, in this report, we do not say new types of providers are the solution. But we do say there's no evidence that makes us say we shouldn't continue to explore new types of providers. We do need more research. We need to know how to more effectively and efficiently use what we have. In the past, a lot of workforce studies have focused on numbers. Do we have enough of this? How many numbers do we have of this? And really, the thinking largely is changing from that to, do we have people that can provide the care that is needed? We're thinking, more functional. Are there enough people to provide the care and services that are needed? Not compartmentalizing by type of provider. And we do need more evidence on the impact of new workforce models on access. So, to have a small study here, a small study there, and see more people are being cared for. But what we really need to see is it overall improving the access? Like I said, we're concerned at the population level. And this is where I emphasize what I've already said a million times. This was a conclusion in our report, no single workforce model will likely serve the needs of all vulnerable and underserved populations. So I also wrote down a couple notes here before I switch to questions. Again, interdisciplinary training. When I talk to you about physicians and nurses needing to learn about oral health and provide preventive care, it's not in replacement of you. You need to work with them as your colleagues to get them to understand what they should be looking for. Most children still are going to, I think it was mentioned earlier, are going to likely come through the medical healthcare part of the system. They're more likely to see a pediatrician than you. And it would be great if the pediatrician could say, hey, I see something wrong here, some discernible pathology. I don't know what it is. I'm going to send you to my colleague. That's really the way a system should work. And I'm going to preempt the first question. When we were asked yesterday, what was the question, we most feared being asked, or was always the hardest question to talk about, is people will say, aren't you creating a two-tier system? Aren't you creating a system where some people get to see the pediatric dentist and somebody else has to see somebody else? And the best response I've heard to that is, we already have a two-tier system. Some people get care and some people don't get care. So again, I'm not talking about somebody who is unqualified to care for people that can't get to you for some reason. What I'm saying is we need to think of different models that have qualified people to do some things that can then, if more care is needed, can channel to the other type of people. And I kind of want to tie back again to what I said originally. Policy is always difficult to talk about when you talk at the individual versus population level. If your mom had cancer and you live in New York City, you'd want her to go to Sloan Kettering or you'd want her to go to Mayo. But a system for our entire population can't have everybody going there. We have to think about ways and models that everybody can get a basic quality care that they need. So with that, I will turn to questions.
Thanks. So in the next 5 to 10 years, do you see there being a role or even a need for, these type of mid-level providers in underserved pediatric populations? And if so, what type of services do you think they will provide or should provide?
I think that in the next years to decades, we are going to be looking, not just in dentistry, but in all professions, at new types of providers. Various levels of training are needed to do different things. Something you're going to hear about, I think, after me, and you've already heard before about, is not everyone has the same risk level. Not everyone needs to see the highest trained person. I do agree that people with the most training, again, you've had the most training, you're going to be more likely to recognize things that other people haven't been trained to recognize. But I don't think from a larger policy and thinking of our population, we're not going to be able to design a system where every child can see a pediatric dentist. It's probably not feasible from supporting a practice like I said, there are children in rural areas that just are never going to be able to get there. I think what needs to be done is, again, to work together to try to determine what are some basic skills that people can have to be sort of the first line to get at a lot of underserved populations, and then, when needed, get to higher levels of care. But do I think that's going to happen? I would also say it's happening. It is happening. A lot of people have likened the role of expanded training of certain types of dental providers to the nurse practitioner field. And I've anecdotally had people say to me, this field is where that field was 50 years ago. So the discussions and the arguments and the fights that are happening were happening in that field. And they continue to happen. Again, I'm not going to say it solved the problem there either, but it is happening. And as opposed to trying to fight it and argue against it, I would say the better approach would be to say, let's work together and decide what is the role for this type of person, what do we think they should do, should not do, and how can we support them and work together so that it works effectively.
Thanks.
This is less a question, more of a comment. Thank you for mentioning the opportunities with the non-dental providers. I know it's really easy for us to remember to talk to the physicians, but not knowing what a nurse practitioner does with my patient when he or she has them. Or my favorite was the pharmacist. Egon, I call him Egon, he looks like him. My pharmacist is getting a call from me when I get home, because now I need to see what questions are our pharmacists fielding right now. That was a very insightful thing to let us know their motivations, because then we can help them better.
Right.
Go ahead.
I agree. No, I've sort of tried to take a step back and say, I'm a podiatrist. I've been where you are, and you've trained very hard, and you're thinking about how to provide the best care to your patient, but you're shortly going to be stepping into a world of health care. And the way ideally it should work is everyone is working together. At the Institute of Medicine, we talk about patient-centered care, and a lot of people talk about patient-centered care, but in an ideal world, that's how it happens. There's somebody once talked to me about what's the difference between multidisciplinary care and interdisciplinary care. And I thought the greatest example I heard was, imagine you're a patient in the hospital, and your internal medicine physician comes in and looks at your chart and writes a note. Then your nurse comes in and writes a note. And then your physical therapist comes in and writes a note. Have any of those people talked to each other? Have they read each other's notes? That's multidisciplinary care. Interdisciplinary care, which is what we're really looking for you to be a part of, is having all those people talk together about a care plan for their patient, and for a particular patient. Again, from the geriatrics world, there is a model of care called the PACE model, where it's an adult daycare and healthcare setting, and they have everybody sit together to talk about the patient, including the driver of the van that brought the patient in that day, because what they have found is that person sees the person every day and is the one who first notices they're not acting right. Something's off with them. So there's lots of people we need to think about. The pharmacist may be the person that sees the patient or the individual more often than you, and something's off about them. Did you know they've been complaining for the last 3 weeks about X? So I do think we need to think more broadly about who's part of our healthcare team.
I think the issue of oral health, okay, I keep going. I know people talk about care. I'm a pediatric dentist, but I keep going to the issue of the health. Mm-hmm. And I think once we get oral health to be culturally assumed, then all this care stuff will then start happening very, very well. Two, it's funny, dentistry, as much as any health discipline that has different specialties, doesn't work well together. But in fact, it has one example that generally works incredibly well together. And that's when you go to a center that has a craniofacial team. Cleft palate team. Those people sit together, look at the patient, they talk about it, they come up with a plan 6, 12 months with the parent, and then they go forward, and then they reconvene to see how they're doing. Third, in the developmental disability population, never ceases to amaze me when I see a patient, or maybe a patient of mine who's at a community-based center, and their primary aide comes with them, okay? And I know I can ask that primary aide about their oral health, if that's the one who's providing it. And it's interesting, if their mouth is straight, everything else about that person is on point.
So getting the public to understand the importance of oral health, and everybody to understand the importance, is still a challenge. I think you living in this world, and sometimes you may assume that that's the case. So the Surgeon General put out a report in 2000, Oral Health in America, and it called early childhood caries. It was like the most common chronic condition among children that exists. And yet, when we were doing our study of the Department of Health and Human Services, we found examples where within, I forget which branch, but they were listing the most important problems of childhood, and that wasn't even on it. You know, oral health wasn't on the list, and we criticized, we were critical of that. There were examples of the CDC, and I don't know the current status of it, but downgrading their oral health division into a branch that was sat within kind of community care. And so on the one hand, while we were working with them to increase their attention to and prominence of oral health, we found examples of they themselves sort of downplaying the prominence within their own system. So that's incredibly important. And craniofacial teams are an excellent, excellent example of teamwork and talking to each other. Since earlier people had given personal anecdotes, I'm currently a patient of the Kaiser system of care, and my family was horrified. I'm going through some health issues right now, and they were horrified that I was in an HMO and how horrible it was. And I have to tell you, I think I've received the best care of my life there, because all of my doctors there talk to each other, and it's been shocking to me. I went into a surgery, and the team actually gathered around me, the surgical team, and each of them introduced themselves, told me what their role was in my care, and they all clarified with each other what procedure I was having that day and why. And I have to tell you that as someone that's probably more educated than your average patient, I was blown away by that, because that doesn't happen a lot. Okay.
Have you seen that electronic medical records have played an important role in interdisciplinary care?
You know, I think you're going to get probably a little bit, maybe more this afternoon on that. My knowledge of that is a little bit more limited. I think I think it's ideal. It's certainly going to help communication. As a patient of Kaiser, again, I will tell you personally that I love my medical record. I go on, I check my own stuff, but I'm also a more engaged consumer probably than most. It certainly was nice getting my test results quickly, at least my positive test result, my good test results quickly and by email. That's another one of those things that I think is obvious and inevitable. I think a lot of people are resistant, and we have a whole other IOM report actually on health records. But it's definitely part of communication and part of us being on the same page of care.
Tracy, I'd like to bring this home to the current trainees with something that we talked about as a group yesterday at lunchtime. There were two themes that kept coming up about the role of the pediatric dentist in the future that I know is of concern because I've heard about it from our residents more than a few times. One suggestion is that a theme is across healthcare, that people practice at the level of their highest skill and delegate anything below that. So to a pediatric dentist, that sounds like, wait a minute, I'm only going to get the tough kids or the kids who've got the worst dental condition. They either behave the worst or have the worst dental condition. And so I'm wondering what your thoughts are on that. The second one is that I'm going to be managing teams. And I've had residents rightfully say to me, I didn't get into this to manage teams. I got into this to provide one-on-one clinical care. So could you address those two from the perspective of their concerns going forward?
Sure. So when thinking about whether you, as the highest trained person in providing pediatric dental care, is the right person to be heading the team, or if you should only be doing your highest level of skill, what I would say is, first of all, nobody's going to not allow you to do the things that you are trained to and want to do. You're always welcome to do that. I would say that you do need to think about what are the things you really need to do and what you can delegate to other people that are part of your team. And we do know that team-based care provides the best care. And so you need to think thoughtfully about how you can use people within your own practice effectively and efficiently so that you can do more of what you've been trained to do and hopefully want to do. I don't think any of you have gotten this far in your education and training to do a basic fluoride varnish application. Maybe you want to do some of that, but I don't think that's what you want to do 90% of your day. I could be wrong. You could tell me otherwise. But you are the person that knows how to do those things the best, and you need to think about having a team. I think thinking that you're going to work in isolation from this whole larger workforce that I discussed with you is unlikely, especially if you do want to provide the best care for your patient. You need to be engaging more with your pediatricians in your wherever you set up your practice or go into practice. That's only better for you. There should be a referral back and forth between you. You should have an ongoing relationship and discussion with them. They don't know what to look for unless you tell them or you teach them if they haven't had that training. Again, to bring it to myself, I as a podiatrist, I used to go talk to primary care physicians all the time about ingrown toenails because I found that patients were coming in, and this is again my experience, they wouldn't have their patients take their socks off if they were cold. So if they don't know to look in the mouth or what to look for, you're not going to have a team. I would agree that while I think you do have a role to play in being the manager of a team, I don't know that the current educational system prepares you well for that. We do need to think more about the specific skills that are needed to be a manager, to be a supervisor. Nursing has had a lot of these struggles with not having the skills needed for nurse supervisors to be supervisors. That's a distinct set of skills. And like I said, the skills that are needed to work on a team with people of other professions. I do largely think we are training you to do what you do and then expect you to go into the world and work together, which is unrealistic.
Thank you. Any more questions? Please.
You're mentioning a lot about the disparity of, oral health education and things like that, and you brought up a few programs that have been started to educate, residents or med students or things like that. What's stopping that from getting put to the next level? What's stopping that from saying every medical school needs to be training all their students and residents on oral health? Every one
Right.
has to go through this tutorial or shadow a dentist for a day or something like that. Where's that disparity?
So I think there are two major reasons why that oral health education is not being more widely incorporated to our non-dental professionals. The first is still getting the heads of medical schools and other types of professional schools to understand that it's important. It's a basic literacy issue. Or, I should say three things. Number two, they'll say, oh, well, we're covering it. But again, there's always a question of what the quality and extent of education is. When people say they're providing oral health education, that could be an elective 1-hour lecture over a lunch. It could be a 2-hour lecture in the first year of medical school. And that's often what it is. It's very isolated like that. The last one is, and you'll hear this with every type of new thing that wants to be introduced into education, is we're already teaching so much we don't have the time. What else should we, what is this going to be in lieu of? And so And that's a real question. It is a real struggle. And I think it also gets to the question of, are we expecting certain types of professionals to know about too much or know about everything? And that's where there is value in having the more specialized training, because we need sort of the basic level of person who can recognize there's a problem and then know who to send people to.
Thank you. Thank you. Oh, we have another question? Sorry.
We've heard about barriers in obtaining health care in general and underserved population. Could you identify some of the highest ones that are up there that are main obstacles keeping people from being able to obtain?
Well, I think it does start with literacy, with people knowing that they need to get care. I'm sorry. So some of the basic barriers for why people can't access care, or at least perceive they can't access care. The first would be basic oral health literacy, knowing that they should go to a dentist. I've heard people say, I didn't know it wasn't normal to have pain. I just thought that's how it was supposed to be. I gave an example of people believing that it was okay at 18 to have a full set of dentures. There's a lot of literacy issues out there. Other major barriers, geography, people that live in places where they just simply don't have access to types of professionals. And this is where I really didn't talk at all about teledentistry that's come up as part of our solution. And that is I should have concluded that is a workforce issue of a way to get some basic screening and assessment done. There are communities where if it's a low income underserved population, there's a lot of debate and discussion, but there are communities where someone with Medicaid can't find a dentist to get to that will accept their care. Within other types of populations aside from children, people aren't going to nursing homes. People aren't going to housebound patients. You all are certainly more highly trained with how to work with children with disabilities. That's an issue. People that are low income, underserved, and are working 3 jobs don't always have the opportunity for an office that's open before 7 a.m. or after 5 p.m. And there's basic, aside from basic literacy, tied with literacy, I would say there's appreciation and value for following up on care. There's a lot of those things.
Thank you.